Good afternoon, doctors. My name is Rajesh Sharma, working as a zonal sales manager at Elan Pharma India Private Limited. And Elan Pharma is a Mumbai-based company having leadership presence in probiotics and oral healthcare products. At the outset, let me thank you for sparing your valuable time to attend this webinar on COVID-19, the scenario. I take the honor to introduce Dr. T.M. Khan. So it is very difficult to describe about Dr. Taj Muhammad Khan. As per my opinion, he is a very loving personality as a doctor. Dr. Taj is a senior consultant, cardiac physician, and Dr. Taj is life member of CSI and associate member of UPSCI, RAM. The rest of the panel will be introduced by Dr. Taj Muhammad Khan. So with this, I would hand over the session to Dr. Taj Muhammad Khan. Sir, Dr. Taj. डॉक्टर ताज मोहम्मद खान सर, आप सुन पा रहे हैं मुझे? डॉक्टर आप शुरू करिएगा अभी थोड़ा सा अपना ये अनम्यूट कर दीजिएगा. अनम्यूट सर प्लीज.
हेलो.
यस सर, यू आर ऑडिबल. प्लीज स्टार्ट.
मिस्टर राजेश, थोड़ा सा प्रॉब्लम हो गया था, यहाँ पे डिस्कनेक्ट हो गया. हेलो
सर, आप शुरू करिएगा. हेलो,
अभी डिस्कनेक्ट हो गया, यहाँ से नेट डिस्कनेक्ट हो गया.
डॉक्टर
कोई बात
बोल
नहीं
रहे हैं क्या सर?
अच्छा, डॉक्टर ताज आ गए हैं. Yes. Sir, now your PPT is
नाइला का शायद डिस्कनेक्टेड है, उसको मालूम देख लो.
कोई बात नहीं सर, आप शुरू करिएगा.
अच्छा ठीक है,
आप शुरू करिएगा. मैं ना डॉक्टर नाइला से मैं बात प्लीज.
You had given this introduction. Have you given the introduction?
Yes. We have started.
You have given the introduction.
Yes, sir. We have started. Just you present your presentation right now.
Okay. Good evening, ladies and gentlemen. First of all, I must thank the Elan Pharma Company who had given us this opportunity to present this webinar. Today's webinar will be on COVID-19. Today's webinar is on COVID-19. As we know, it's recently been creating havoc in the population. We have two more speakers, myself and representing the medical part of it and the epidemiology of the COVID, and Dr. Arif Siddiqui. He's an eminent surgeon at Rampur. He'll be presenting this. We've got another eminent, very young, dynamic speaker with a lot of energy, Dr. Naila Siddiqui. He's MDS. She's MDS. She'll be presenting the problems with the dental surgery and facial maxillary surgery in COVID patients. Ladies and gentlemen, the first presentation is mine, presenting COVID-19. Is a disease there's no disclosures, of course. And this is a distribution of the disease in various countries. And you know, USA counts about 31.67% of the patients, number of patients in the world over. And India counts about only 2% of the disease, 2.07%. And you know, the number of patients in America all over the world is about 47 lakhs 35,622, and death occurred so far. These are data collected yesterday evening about 6:30 p.m. These are data presented by WHO. The deaths are about 31,629. In India, we had till yesterday about 1,139 patients, and the deaths occurred so far is 3,169. 63. I think everybody knows this gentleman. He knows, knows everyone he desires, and even in COVID patients, he's talking about the disease, about the pandemic, and he's talking about the treatment also, which is not capable of. So my point is, we should not listen to those people who are not capable of talking and not quoting medical literature. So now back to the COVID-19. The correct name of the disease is COVID-19. The clinical disease term COVID-19 is caused by novel beta coronavirus, now named as SARS-CoV-2. The SARS-CoV-2 is the seventh coronavirus known to infect human beings. 2019 novel coronavirus is a new virus that causes respiratory illness in people and can spread from person to person. The virus was first identified during an investigation into an outbreak in Wuhan, China. This large COVID-19 virus is a large family of the envelope RNA viruses, belongs to a sub-Sarbevorous subgenus of the coronavirus family, and is the seventh coronavirus known to infect human beings. The full genome has been determined and published in GenBank. We had two earlier epidemics by coronavirus. These are MERS and SARS. Middle East Respiratory Syndrome and Severe Acute Respiratory Syndrome occurred in 2003 in China and other countries nearby this. And MERS occurred in 2012 in Saudi Arabia. Now we have new strain of the coronavirus causing COVID-19. This is the structure of the virus. I'm not going through in detail of the structure. The epidemiology started, the first case was noticed in 2019 December in Wuhan, China. And since then, in the last 3 months till March, we had a pandemic. The disease so much to the world over and caused a pandemic. WHO declared it as a pandemic. The initial presentation of the disease is simple upper respiratory infection with fever and cough. And ultimately, this is the most is everything all right? Hello?
No, no audio, no video, nothing. We don't have audio or video. No presentation, everything gone.
Hello?
Hello? Yes.
सर आपका सिग्नल शायद कुछ कम हो रहे हैं, तो आप दोबारा से स्क्रीन एक बार शेयर करिएगा.
Is it hello?
शेयर, हाँ सर, शेयर करिए स्क्रीन दोबारा से. शायद perhaps Dr. Taj Mohammad Khan link is not with us. So should we start with Arif sir? Arif sir, please start your presentation. I think the connection is not.
Hello?
Dr. Taj, are you back?
Yeah, I'm back.
Okay.
Can you see my slide? Is it okay now?
We
Hello?
can't see your slide. Hello, we can't see your slide right now.
Yes,
Is it okay now?
You.
yes, ma'am. Yes, ma'am. Okay now.
Okay. Now we were there that the time taken from less to severe disease status is about 9 to 10 days. Okay. Is it fine? Everybody is listening to seeing the slides.
Yes, sir.
Okay. Now how does the transmission occurs? You should know it. Coughing and sneezing without covering the mouth can disperse droplets into the air, spreading the virus. Touching or shaking hands with a person that has the virus can pass the virus from one person to another. Making contact with the surface or object that has the virus and then touching your nose, your eyes, your mouth will cause you infection. On rare occasion, coronavirus may spread through contact with feces and semen. And this diagram depicts how the infection occurs, and you see the individual coughs out and the droplets goes into the air, and the airborne droplets being inhaled by the susceptible individual. On the other side, you see the direct contact with the surface, the virus being dropped on those places, and these contacts will have an infection if they touch those surfaces. Now, about 80% of these cases of the COVID-19 disease, are a mild disease. We do not have much problem with these patients, but about 15% of these patients comes in a severe state, and 5% of them are in a critical stage, need treatment in the ICU, in a separate hospital, in intensive care hospitals. And the mortality, as far as mortality goes, the more mortality occurs in older people of more than 80 years of age. The mortality rate is about 14%. The patients with cardiovascular disease and other comorbidities such as diabetes mellitus, hypertension, malignancies will have a more mortality. And the overall mortality of the COVID-19 disease is 0.25 to 3%. Now, what do we know about the pathophysiology of a disease? The incubation period ranges from 1 to 14 days. Asymptomatic patients found to have similar viral load compared with symptomatic patients. This is to be noted. High viral loads have been detected in nasal and throat swabs. It is thought that virus binds to the angiotensin converting enzyme 2, that is ACE2 receptors in the human beings, thus enters the body. Now, what are the symptoms of a disease? The majority of the symptoms are in the form of fever, dry cough, fatigue, anorexia, sputum production, and myalgia. Myalgia is so severe that once somebody had it, he will remember it throughout his life. The less common symptoms are sore throat, diarrhea, dizziness, and nausea and acousia. This is occurs in about less than 10% of the patients. Now, what happens when you had a disease? On day 5, that is after the incubation period, patients experiences fever and possibly also fatigue, muscle pains, and dry cough. A few may have had diarrhea or nausea 1 to 2 days before the illness. On day 5, the patients who are older or have pre-existing conditions have difficulty in breathing. On day 7, patients with breathing difficulties are admitted to the hospital, but most patients' symptoms start to diminish by this time. On day 8, severe cases develop signs of acute respiratory distress syndrome, where lungs can't provide vital organs with enough oxygen. On day 10, patients with worsening breathless problem enter into intensive care unit and needs intensive management. Fever on day 12, fever usually ends, but cough may linger on. In survivors, difficult breathing ceases after about 13 days, while the average time for death is about 18.5 days. What are the risk factors if a person has the disease of COVID-19? The patients with acute illness, liver injury, bedridden status, genetics, COPD, CKD, heart failure, malignancies, diarrhea, sepsis will behave badly. The inflammatory responses which occur with these diseases, endothelial dysfunction, superinfected, and we have decreased tissue factors such as TFP1, lymphopenia, inflammatory cytokinins, that is increased interleukin 6 and CRPs. There are hemostatic abnormalities which occurs in the disease. This is the form of micropulmonary emboli, intravenous coagulopathies, myocardial injury, and increased cardiac biomarkers. The D-dimer increase suggests that there's a lot of pulmonary injury, and there can be decreased platelet counts. The clinical outcomes occurs in the form of venous thromboembolism occurring, causing pulmonary embolization, myocardial infarction, and disseminated intravascular coagulopathies. The News Hindustan Times suggested that 50 to 82% of the COVID cases in India are asymptomatic. This is very much to be noted for. And the COVID disease, when compared to flu and common cold, there's so many things in common, except the incubation period in COVID virus is about 1 to 14 days. With flu, you have 1 to 40 days. The common features are symptoms, fever, cough, fatigue, and running of nose. The uncommon features are breathlessness, shortness of breath, respiratory issues, and loss of appetite, and headache, severe myalgia, which occurs in COVID patients only. Now the question is when to suspect the patient is having COVID disease. There are very classical features one should know about it. Any symptomatic individual who had international travel in the last 14 days is a suspect. All symptomatic contacts of confirmed cases are suspects. All symptomatic healthcare workers need to be cared for. All hospitalized patients with severe acute respiratory illness are suspect patients. Asymptomatic direct and high-risk contacts of confirmed cases that is tested between day 5 and 14 are suspects. Now, we had the COVID patients, when they are asymptomatic, they hardly needs any hospitalization, but few of the patients who are symptomatic and symptomatic cases and severe cases needs hospitalizations in a separate care hospitals. Where do we have about dedicated treatment for this COVID disease? Between 5 and 8% of the, scientifically speaking, between 5 and 80% of patients, people testing positive for SARS-CoV-2 may be asymptomatic. And when to seek care in these patients. Most of the patients are advised to stay home. Going to the hospital or a doctor's office add to a higher concentration of people and further overwhelming medical staff. You need to call for an advice if you are ill but would not have sought care if not COVID-19. Do not seek care at an emergency room, hospital, or a doctor's office. When you should seek care is if you are sick and feel you have an emergency, please call your doctor or seek a medical care. You have got many helpline numbers in your districts. Now, what is the strategy for COVID-19 testing in India? The first of all is all symptomatic individuals. You should take a note of these guidelines. All symptomatic individuals who have undertaken international travel in the last 14 days are to be tested for. All symptomatic contacts of laboratory confirmed cases are to be tested for. All symptomatic healthcare workers, if they develop symptoms, are need to be tested for. All patients with severe acute respiratory illness, fever and cough, and a shortness of breath are to be put in for testing for COVID-19. Asymptomatic direct and high-risk contacts of a confirmed case should be tested, and once between day 5 and day 14 of coming in the contact of a patient. In a hospital, cluster, and in large migratory gatherings, evacuees centers, the Ministry of Health and Family Welfare suggests that all symptomatic influenza-like illnesses, fever, cough, sore throat, running nose, to be tested for RT-PCR within 7 days of the illness, and after 7 days of the illness, antibody test, if negative, confirmed by RT-PCR. The presentation of a disease sometimes come in the form of uncompleted illness, mild pneumonia, severe pneumonia, acute respiratory distress syndrome, sepsis, and septic shocks. These are the common presentation of a disease COVID-19. Laboratory testing, reverse transcriptase polymerase chain reaction, that is RT-PCR test, can detect SARS-CoV virus in a clinical specimens such as blood, stools, and nasal secretions. Serological testing also can be performed to detect SARS-CoV virus antibodies produced after infection. Finally, viral cultures has been used to detect SARS-CoV virus. This slide is very important, giving many data which one must remember. Day 0 is in date of infection, up to day 5, onset of symptoms. On day 7, the IgM antibodies appears in the blood. On day 14, IgG antibodies appears. From day 1 to 18, SARS-CoV-2 RNA and antigen will be positive. On day 21, IgM disappears. On day 28, SARS-CoV virus RNA and antigen disappears from the blood. From day 0 to day 5, the patients are mostly asymptomatic. From day 0 to day 7, window period, only PCR is positive in this phase. On days 14 to 21, declining phase, still patient is infective. On day 1 to 28, convalescence phase, but the patient is still infective and shedding viruses. This diagram depicts the various stages and time of the antibodies and antigens. From day 0, you have a positive antigen. From day 7 to day 21, you have positive IgM appearing in the blood. And from day 14 to more than 35 days, the antibody IgM remains there in the blood. Now, a few words about the herd immunity. Many people are talking about the herd immunity because this immunity causes the disease disappearing from the community. The whole principle is that enough people in the community develops and gets protection by infection or vaccination. This is the herd immunity. They are both protected from infections and are also don't transmit infection to the vulnerable people in the community. Herd immunity protects vulnerable people in the community, that is the elderly, those suffering from immunosuppressive diseases such as HIV, AIDS, cancer, those on immunosuppressive medications, babies and people with vaccine allergy, those who have not received vaccines. They become safe with this development of the herd immunity. It is estimated that 50 to 60% of the people, when develops herd immunity, then you are safe. Then it is said that disease is being in a declining state. These are the various antibodies and antigens showing the levels in the human beings in COVID-19. Now, what is the strategy for the use of rapid antibody-based plus test? The strategy is in clusters and large migrating gathering. You need to do, and the patients with symptomatic influenza-like illnesses, you need to do rapid antibody test. That is, if it is positive, then probably COVID-19 clinical assessment to be done and home isolation this patient to be advised. And if it is negative, then you go for PCR. If PCR is negative, then it is COVID-19. If positive, there is COVID-19. If negative, possibly non-COVID illness. If PCR not done, home quarantine for 14 days, antibody test after 10 days to be done. And if it is positive within 14 days, you have a COVID disease. If it is negative, possibly non-COVID disease. So this is being rapid antibody testing in community and in patients with clusters and large migration gathering. How does diagnosis help in these patients? We test for molecular tests and serology and other tests in these patients. For molecular testing, we detect the presence of a virus genetic material in the sample. And for antibody, we detect the presence of antiviral antibodies in the sample. And antigen detects the presence of viral proteins, that is in the antigen in the sample. And such other tests we do during the treatment of these patients. The molecular tests are diagnostics. that detect viral genetic material usually performed in a laboratory, and point of care of tests or diagnostic that can be performed outside the laboratory. These are antibody tests. Certain lab findings are important in these patients, such as elevated day gamma. It indicates the prolonged prothrombin time. Elevated serum troponin indicates elevated serum prolactin indicates this is a marker of the sepsis. Elevated serum lactin dehydrogenase indicates myositis. Elevated serum creatine kinase again indicates myositis. ABG may show low partial oxygen pressure. It indicates lung involvement, severe lung involvement if it is reduced. Pulse oximetry may show the low oxygen saturation if there is lung involvement. Now, a few words about the RNA testing, that is antigen testing. Detected by RT-PCR. Sample is taken from nasopharynx. Other oropharyngeal nasal swabs are accepted. Positive test confirms infection. False negative and positive test low but documented. They can occur a false negative test also. If negative and suspicious, high samples from lower respiratory tests are to be advised. The other test known as AIOD test, which gives information within 5 to 20 minutes. We are not doing it. This is an experimental. Gene expert, we have other test expert express SARS-CoV virus. And this gives information within 3 to 4 hours. The laboratory samples are required, are collected from nasopharynx and oropharyngeal swab, bronchoalveolar lavage, endothelial tracheal aspiration, nasopharyngeal aspiration, nasal splash, and sputum, tissue from the biopsy of autopsy, including from lung, serum samples, and whole body. And urine samples. Sometimes we need them. Other investigation needed in these patients is the chest X-ray and high speed
Hello. Hello.
Hello.
Yes, sir. आपका लिंक फिर टूट गया था.
हाँ, लिंक टूट गया. There is some problem with the internet.
कोई बात नहीं. सर आप दोबारा से.
I'm back, eh? I'm back now.
Yes, sir. It's
You
okay.
can see my station.
Yes, yes.
The management goes as far as we have modality in the form of treatment and prevention. The management of these patients is to be done in COVID-designated hospitals. Different countries and different localities have different policies across, and we have got TRIDET institute-oriented policies, which patient to be managed on a OPD basis, mild disease with no comorbidities and risk factors. These are the patients to be managed in OPDs. Which patients need hospitalization care? Which patients need ICU care? Should all patients be given COVID-19 targeted treatment? When could the patients be discharged? Or to be decided by the protocols of these hospitals. The general measures include adequate fluid intake. If the patient is diabetic and patients with chronic kidney disease or heart failure, they need special care. Frequent self-monitoring of glucose in this patient is required. Check for indicators if persistent hypoglycemia is there, and manage hypoglycemia if it occurs. In a mild disease, we have to manage at home. We have to manage this patient at home. Follow general measures. Advised to be in touch with healthcare providers. managed with ongoing medications need not to be modified if there is any comorbidity. For a severe disease, you need to have certain tests to manage these patients. You need to screen for coagulation abnormalities, serum troponin, serum prolactin, serum lactate dehydrogenase, serum creatine kinase, and ABGs. General treatment issues. Secondary bacterial infection now not prominent in COVID disease. Empirical oseltamivir is in question. Prophylaxis for venous thrombolysis for hospitalized patients is to be required in severe patients. Avoid nebulization. Nebulized medications use MDIs only to avoid risk of aerosolizations. Non-pharmacological interventions. I'll be talking about the medicines, the drugs also, but there are certain non-pharmacological measures also. Social distancing and distancing measures nationally would definitely stagger the impact of the pandemic. Should be complemented with other measures such as test escalations, treat according to the severity, hospitalize only those requiring in-house care, isolate the COVID cases, contact testing and screening, quarantine and contacts. There are 6 ways you can help to prevent the spread of COVID-19. First of all is clean your hands, often with soap and water. Avoid close contact with those not feeling well. Stay home if you are someone in your house is sick. Cover, cough, and sneeze with cleanliness. You have to develop these habits. Wear a mask if you are sick or taking care of others who are sick. And lastly, clean and disinfect frequently used surfaces. Now, what is the clinical measurement of a disease? There is no specific treatment for COVID-2 infection. Clinical management includes rest and avoid overexertion. Drink enough water, avoid smoking and smoky areas, take acetaminophen, ibuprofen, naproxen to reduce pain and fever. A few words about the chloroquine and hydroxychloroquine. It blocks the viral entry into the host cells, inhibit glycosylation of the host receptors, inhibiting proteolytic processing and viral cell, increases lysosomal pH, thus blocking the viral cell fusion. It's immunomodulatory effects through inhibition of the cytokine production, thus causing prevention of the autophagy and lysosomal activity in the host cells. COVID-19 specific treatment. Agents previously used to treat SARS and MERS are potential candidates for the prescription of COVID-19. The meta-analysis of SARS and MERS prescription studies found no clear benefits of any specific regimen. These regimens were chloroquine or hydroxychloroquine, lopinavir, ritonavir, and umifenavir. Now, what is the advisory of the ICMR for hydroxychloroquine? Asymptomatic healthcare workers in care of suspected
Signals again disrupted. Hello.
Hello. Hello.
आप अपना दोबारा से स्क्रीन शेयर करिए, दोबारा से प्रेजेंटेशन शेयर करिए सर, प्लीज. Yes, now it's visible. Yes, sir. Yes, it's visible.
Now, we were there on the ICMR advisory on HCQS. The contradiction is the persons who are less than 15 years of age and those with retinopathy and hypersensitivity. So we have, this is how the various drugs act, certain antivirals and chloroquine and hydroxychloroquine. On tocilizumab is another drug used for cytokine storm. I'm not going to discuss all these details. Now, the European Society of Cardiology issued a guidelines for this disease. The guidelines says follow the rigorous evidence before evidence, ending and starting a treatment. NSAIDs and stomipene, please do not discontinue these drugs. ACE inhibitors, the show must go on. You continue with all these ACE inhibitors if the patient is on ACE inhibitors. Chloroquine, think twice before starting the chloroquine. Now, what about the vitamin D? This is a useful drug for patients with COVID-19. Now, clinical management and treatment of COVID diseases. Healthcare personnel should care for patients in airborne infection isolation room. The standard precautions, contact precaution, and both precautions with eye protection should be used when caring for patients. Healthcare workers need to wear surgical masks and, if possible, goggles, gowns, and gloves. However, emergency room personnel, dentists, doing procedures and anesthetists must wear N95 masks. As a procedure, they do cause exposure to the aerosolized body fluids. Clinical data of the management of COVID-19 disease. We have certain clinical data for the management of disease. There's 4 groups of the patients: mild, moderate, severe, and patients with critical state. And in patients in critical state, severity, as the disease becomes more serious, you need a lot of resources for the disease. You need in the form of manpower, hospital care, and hospital staff. You need a lot of resources for these patients. COVID-19, is there any treatment for the antivirus and other chloroquine, etc.? Yes, there were no definite proofs for these drugs at present. Azithromycin and hydroxychloroquine, this has been recommended, and in open label non-randomized clinical trials evaluated the efficacy of hydroxychloroquine and azithromycin for the treatment of COVID-19. There was about 39 patients treated with these combinations, and at day 6, 100% of the patients treated with hydroxychloroquine and azithromycin combinations were biologically cured, compared to 57% treated with hydroxychloroquine alone and 12% in control group. Other studies also suggested that synergistic effect combinations of hydroxychloroquine and azithromycin. The role of hydroxychloroquine, I just said in the earlier slides. This is how the hydroxychloroquine acts. ICMR recommendation for COVID-19 use of hydroxychloroquine for prophylaxis for selected individuals as follows. The eligible individuals are asymptomatic healthcare workers involved in care of suspected or confirmed cases of COVID-19. They need about 400 mg twice a day on day 1, followed by 400 mg once weekly for next 7 weeks, to be taken with meals. The asymptomatic household contacts of laboratory confirmed cases needs hydroxychloroquine 400 mg twice a day on day 1, followed by 400 mg once weekly for next 3 weeks, to be taken with meals. Clinical and microbiological effects of combinations of hydroxychloroquine and azithromycin was studied in about 80 patients. A rapid fall of nasopharyngeal viral load was found in these patients in about 93% of the patients. This allowed patients to rapidly discharge from the highly contagious ward with mean length of stay of about 5 days. Now, these are the revised guidelines of the clinical management of COVID-19 by Government of India, Ministry of Health and Family Welfare. These guidelines says that based on the available information, that the following drugs may be considered as an off-label indication in patients with severe disease and requiring ICU. Hydroxychloroquine, the dosage of 400 mg BD for day 1, followed by 200 mg BD or 4 mg OD for 4 days, in combination with azithromycin 500 mg OD for 5 days. These drugs should be administered under close medical supervision with monitoring for side effects, including QTc prolongation. The above medication is presently not recommended for children below 12 years of age and with pregnant women and lactating women. These are the same slide. Now we have other treatment options in the form of drug. These drugs are tocilizumab, ivermectin, convalescent plasma, Atenolol plus lopinavir combinations, and acetaminophen. But these are all drugs did not show any results which to be put in for as guidelines. For protocol of treatment of patients who are hospitalized, we have got 6 groups of these patients. The group A patients are those patients who are asymptomatic, first positive for COVID-19. They need to be hospitalized in isolation ward, and they need to be tested for COVID virus on day 0, 7, and 14. The drugs to be given in these patients are oseltamivir 75 mg BD for 5 days plus azithromycin 5 mg OD for 5 days. The patients were asymptomatic without comorbidities. They are to be tested for virus on days 0, 7, and 14, or to be put in isolation ward. The treatment required is oseltamivir 75 mg BD for 5 days, hydroxychloroquine 400 mg BD for day 1, then 200 mg BD for 4 days, and tablet azithromycin 500 mg OD for 5 days. The C group of patients, that is third group of patients, are symptomatic with comorbidities. They are more than 60 years of age with diabetes, hypertension, ischemic heart disease, COPD, immunosuppressive medications, and malignancies. They are to be put in isolation ward. Needs to be tested for days 0, 7, and 14. The drugs required for these patients are oseltamivir 75 mg BD for 5 days, hydroxychloroquine 400 mg BD on day 1, then 200 mg BD for 4 days, azithromycin 500 mg BD for 5 days. They also be given with lopinavir and ritonavir. These drugs are used for AIDS patients, but they are used in this group also. For days 7 days, they to be given for 14 days. Now we have got D group of patients with pneumonia without respiratory failure. They need to be tested on days 0, 7, and 14, put in isolation ward. The drug treatment is required is same: oseltamivir, hydroxychloroquine, azithromycin, and ritonavir or lopinavir. Now we have group of patients who are with pneumonia and respiratory failure. In this, the frequency of swab collection for COVID virus is being increased from on day 0, 3, 6, 9, 4, 12, and 14. They need to be put in ICU. The drugs required for these patients are oseltamivir 150 mg BD. Earlier we were using 75 mg. Now we are giving 150 mg BD for 5 days. Hydroxychloroquine 400 mg BD on day 1, then followed by 200 mg BD for day 14. Azithromycin 500 mg OD for 5 days. And lopinavir and ritonavir 200 mg plus 50 mg, 2 tablets BD for 14 days. Now this is a group of patients who are very serious and needs lot of care. They needs all these measures which we discussed earlier, plus antiviral drugs in the form of lopinavir, ritonavir, and there needs the treatment for the comorbidities also. They need to be tested for days 0, 3, 6, 9, 4, 12, and 14 days, or to be put in isolation ward in ICU. Ministry of Health and Family Welfare guidelines. They again suggested that for patients with progressive deterioration of oxygenation indicators, rapidly worsening on imaging and excessive activation of body inflammatory response, needs glucocorticoids for a short period of time, for 3 to 5 days. It is recommended the dose should not exceed the equivalent of methylprednisolone 1 to 2 milligram per kg body weight per day. Note that a longer dose of glucocorticoid will delay the removal of the coronavirus due to immunosuppressive effects. For pregnant, severe and clinical cases, pregnancy should be preferably terminated. Consultation with obstetrics, neonatals, and intensive care specialists need to be done. Patients often suffer from anxiety and fear, and they should be supported by psychological counseling. Few words about the glucocorticoids. WHO or CDC should not recommends that should not be routinely administered unless there is separate evidence for base indications. Critically ill patients, data suggests that potential benefits in patients with ARDS provides weak recommendation in patients with COVID-19 with ARDS. Begin with 14 days low dose short courses of steroids, 20 milligram intravenous for 5 days only. Favipiravir is another drug in experimental state used in COVID-19 patients. This is a prodrug of purine nucleotide. Active agents inhibits the RNA polymerase, halting viral replication. Most of the favipiravir preclinical data are derived from its influenza and Ebola activity. Also demonstrated broad activity against other RNA viruses currently available in Japan. The compassionate use of remdesivir for patients with severe COVID disease. At baseline, 30 patients, 61 patients were studied in this study. At baseline, 30 patients, that is 57%, were receiving mechanical ventilation, and 4 patients receiving extracorporeal membrane oxygenation. During medication follow-up of 18 days, 36 patients, that is 68%, had an improvement in oxygen support class, including 57% receiving mechanical ventilation who were extubated. A total of 25 patients were discharged and 7 patients died. Mortality was about 18%. Tocilizumab. This is a monoclonal antibodies receptor antagonist used in severe patients with cytokine storms. This is lopinavir, I discussed it. This is All India Institute of Medical Sciences guideline issued on 18th April. This is the same guideline we have discussed, except that they are discussing the use of low molecular heparin patients in all patients with respiratory illness. That is, the patient had most of the time had coagulopathies and pulmonary embolizations. The plasma exchange therapy. An argument for use of therapeutic plasma exchange for fulfillment in COVID-19 disease is in experimental stage. The prevention of the transmission of the infections. In healthcare setting, infection prevention and control measures include droplet protection, that is wearing a surgical mask, contact precautions, hand washing or wearing gloves and gowns, and airborne precaution. Isolation room with negative pressure. The use of clinical triage for the early identification of patients with acute respiratory infection. Isolation of cohorting of patients is recommended to prevent transmission of acute respiratory infection pathogens. Use of appropriate PPE when providing care to patients with ARDS. Use of PPE and adequate ventilation single rooms when performing aerosol generating procedures. These are various PPEs. This is discussed by subsequent speakers. Now, which mask to use? Something about the mask. If you have COVID-19 and need to be around others, wear a surgical mask. Also plan to wear surgical mask if you are caring for someone at home that can't wear mask. Reserve and 95 mask respirators for use of healthcare workers and first responders. Surgical masks are disposable, don't you reuse them. Clean your hands before putting and removing your mask. These are various masks. This is the N95 mask, which filters about particle matters of 0.3 microns, difficult to wear long time due to breathing difficulties. But all masks labeled as N95, there's not the true masks. That there can be fake masks also in the market. You should be careful about it. These masks prevents the particle filters about the size of the 0.007 micron, and the coronavirus is of the size of 0.1 micron. So you can see these masks are very effective. N95 mask reduces the wearer's exposure to airborne particles. Surgical mask prevents you from spreading the virus to others.
Hello. Dr. Arif, sir,
Yes. Hello.
sir, please you start as again link have been broken. Please,
Okay.
please, sir. Although his presentation is over, I think so. It is very near to over. So, can you share your slides right now?
Hello. Can you see me? Hello.
Yes, sir. Yes, sir. Please start.
Hello. I am Dr. Arif Siddiqui, general surgeon working at Rampur. The idea about this presentation is because up to now we had only one problem to save the patient. Now we have two problems: save the patient and save the surgeon. Therefore, this problem. This is what this show is all about, and these are the people from whom the show is meant for. This COVID-19 pandemic, it has become the priority to protect the healthcare worker, including those in the operation room. This presentation brings together the latest information, data, and recommendation for personnel in operating room, as well as how to minimize the risk of COVID infection afterwards. Now, I have a disclaimer to make. I have not operated or dealt with any corona patient till now. All the data that is being presented here is the published work and is in public domain. Now, ideally, we should test every patient for COVID test for every patient, RT-PCR, for before taking him to operation theater. But many times it's not possible because of lack of resources. That's why all this decision pathways has been formed. Now, to see if you can, if this is an active case, we have to postpone it for future date. If it is not elective case, then we'll find out if the patient have symptoms or is high risk. Patient has got fever, cough, or it's a sore throat or muscle aches, fatigue. Then what do you do? And if it's not there, then straightforward we proceed with the standard precautions: the face shield, surgical mask, double gloves, and avoid contamination of work surfaces with secretions. Now, if the patient have these symptoms, then you have to do the test, COVID test. If the test is positive, then reconsider the case if it needs to be done, or it can be delayed for 14 days. If it can be delayed, then repeat test after 24 hours after the symptom resolved. Okay to proceed once two negative tests. Hello. Hello.
Yes, sir. Yes, sir.
Who is presenting?
So it's your slide, na?
Your
No, it's
slide.
not. It's not my Dr. Taj Mahmood.
I think he restarted his slide.
So,
Yes, sir. Sir, your link is so poor. Hello,
huh?
डॉक्टर ताज
हाँ,
सर, आपका शायद नेट काफी पुअर है, तो उस वजह से थोड़ा ये हो नहीं पा रहा है सर।
अच्छा,
हाँ
अब आ
सर,
रहा है नहीं इसमें?
हाँ आपकी आवाज अभी आ रही है, अब बाकी आपका स्लाइड भी दिखाई दे रहा है।
तो मैं फिनिश करता हूँ, 2-4 स्लाइड्स अभी मेरी, ठीक है?
ओके ओके सर, प्लीज।
Let us continue with the hand hygiene. All healthcare workers should perform hand hygiene using alcohol-based, perform before based hand rubs minimum 20 seconds by washing with soap and water. Perform before and after using bathrooms, before, during, and after preparation food, before and after eating, drinking, and coughing. Blowing or sneezing after touching garbage or after touching masks or soiled PP. Food operators and other sanitizers should be outside elevators, OPDs, screening areas, and ICUs and bars. A few words about the home ACs. Home ACs don't pose any coronavirus threats, but central air conditioning do. So they should be avoided in these patients. What is the future of the COVID disease? Well, we have to do a rapid testing. We have to work it out for drugs. We need to go for the vaccination if it is available, and some antiviral drugs if they are being available. This is the future of the drug, but this disease is going to stay with you. Now the summary. Summary is the take-home messages with COVID-19 disease. This is a pandemic disease going to stay for longer than expectations. We should gradually start seeing OPD patients. We should use proper PPE. We should use proper hygiene, infection control practices. We should educate patients regarding use of masks, cough etiquettes, and hand hygiene. Social distancing principles must be followed in OPDs also. Keep good nutrition and sleep. India, being a country of extreme geoclimatic diversity, faces the constant threat of emerging and re-emerging respiratory infections of public health importance. COVID-19 is a mutant coronavirus disease which affects the lower respiratory tract, causing respiratory and multi-organ failure, leading to death in few patients. Most of the 80% of the patients recover without any problems, and they have a mild disease. There is a need for strengthening disease surveillance in the country, focusing on the epidemiology and disease burden. Also, pressing need to gain detailed insight into the disease biomics, including vector biology and environmental factors influencing the disease. Also important to strengthen the emergency preparation for these diseases and response by focusing on the healthcare approach. What we have learned from this pandemic? The first of is avoid deforestation. Learn to appreciate nature. Importance of talking to the family members, taking a rest when you are ill. Stop eating raw meat. Reserve, respect animals. And if you respect nature, nature will respect you. Thank you very much. Thank you, ladies and gentlemen. Now we proceed Dr. Arif's presentation.
Already we
Okay,
have
Doctor.
4 o'clock right now. Please start.
Dr. Arif, please.
Yes. इसमें कोई डिजाइन तो डाल दो.
अपना अपना अगर आप ये चेंज करें फॉन्ट भी चेंज हो जाते हैं इधर उधर
एक बार देखो इसमें कैसा आ रहा है.
वैसे सही लग रहा है
इनमें नहीं ज्यादा होने के चेंज.
ऐसा हो कोई जो मतलब लाइट साइकिल हो रही मैडम क्लियर
मैडम तो ऐसा से पसंद कराया वैसे.
And
आरिफ सर का ऑडियो म्यूट है, प्लीज कोई कहेंगे उनको अनम्यूट करने के लिए.
hello, hello.
Sir, you're audible. Sir, please continue.
Okay.
Hello.
Yes. Now,
Yes,
while
sir, start.
deciding the priorities, one must take into account safety of the healthcare provider, safety of the patient, outcome of the procedure, availability of resources, MENTS scoring. For this, they have developed a scoring system. It's called MENTS scoring. This is developed by University of Chicago, published by Journal of American College of Surgeons. Is a good option. It takes into account procedure factor, the disease factor, and the patient factor. Now, these are the scoring chart. Here, so many variables are there: OT time, estimated hospital stay, post-operative ICU need, anticipated blood loss, surgical team size, intubation probability, and surgical site. As you see here, the more you go upward, the number increases, the points increases. When you are abdominopelvic, this is abdominopelvic open surgery, this is abdominopelvic open surgery, and this is upper thoracic and yes, it reaches 5. So you calculate the points like this, and this is the disease factor. Is the non-operative treatment option? Is it available or not available? Non-operative treatment of exposure of risk, and this is impact of 2-week delay in the disease, impact of 2-week delay in surgical difficulty risk, impact of 6 weeks delay in disease outcome, and impact of 6 weeks delay in surgical difficulty risk. And this is the disease factor. That comes the third one, which is the patient factor. Age of the patient, COPD, lung asthma, lung disease, obstructive sleep apnea, cardiovascular disease, diabetes, immunocompromised, and exposure to known COVID-19 positive person in the last 14 days. And you accordingly, you calculate the points. Now, if it comes out to around 50, 49, 50, then it's reasonable to operate on him, taking all the precautions. If it is more, then there is more dangerous and worsens worse condition. There is excessive risk to the personal and excessive resource utilization. It should be delayed. Now, issues to be addressed during surgery: the use of personal protective equipment in the operation room, including appropriate donning and doffing of the PPE, anesthesia, intubation risk, specific operative risk issues after operation recovery, leaving the operation room and the facility and going home. What should be done to keep your family safe? The procedural considerations are there is a very little evidence regarding the relative risk of minimally invasive surgery and open surgery. We will therefore continue to monitor emerging evidence and support novel research to address these issues. It is strongly recommended, however, that consideration be given to the possibility of viral contamination to staff during surgery, either open, laparoscopic, or robotic, or that protective measures are strictly employed for OT staff. The practical measures for surgery: consent discussion with the patient must cover the risk of COVID-19 exposure and the potential consequences. If readily available and practical, surgical patients should be tested pre-operatively for COVID-19. If needed, the possible intubation or extubation should take place within negative pressure room. Operating rooms for presumed suspected or confirmed COVID-19 patients should be appropriately filtered and ventilated, and if possible should be different than others where other emergent surgical patients are being treated. Negative pressure rooms should be considered if available. Only those considered essential staff should be participating in the surgical case. All members of the OR staff should use PPE as recommended by the national or international organizations, including WHO or CDC. Appropriate gowns and face shields should be utilized. These measures should be used in all surgical procedures during the pandemic, regardless of known or suspected COVID status. Placement and removal of PPE should be done according to CDC guidelines. N95 respirators that offer a high level of protection should be used when performing or present for an aerosol generating procedure. Disposable respirators and face masks should be removed and discarded appropriately in accordance with the local policy. Perform hand hygiene after discarding the respiratory or face mask. Now, this is in a nutshell. Ideally, no stop. When you transfer the patient to OT, ideally no stoppage in corridor, holding area, and take patient straight to the dedicated operation theater. Social distancing in the lift as far as possible. For non-GA patients, ensure that they are wearing a mask throughout the procedure. For non-intubated patient, must wear disposable waterproof gloves and disposable cap and shoe cover during the transport. This is in the form of a chart, the route, the fixed path, the patient from here, it should be fixed path, shortest possible route directly to the OT. All the materials after the surgery should be replaced before starting his procedure. Dedicated trolleys and metal baskets and the bare necessity should be there. Whenever possible, try not to refill during surgery. Patient should be shifted directly and quickly to OR. Manual replacement, material replacement by PPE equipped personnel from outside. They should not come in from inside the OT to outside, and outside person should not go to OT once the patient has gone inside. Close the patient entering, clear, airtight, alert signal on the door, high rate of exchange cycle. Air exchange cycle should be more than 25 per hour. This is the photographs of PPE and masks. The donning and doffing of the PPE is very important. First, identify and gather the proper PPE to don. Ensure choice of the gown size is correct. Put on the foot cover while sitting. Perform hand hygiene using hand sanitizer. Put on isolation gown. Tie all the ties on the gown. Assistance may be needed by another healthcare provider. Put on N95 filtering face piece, respirator, or higher. Use a face mask if respirator is not available. Respiratory face mask should be extended under the chin. Both your mouth and nose should be protected. Do not wear respirator face mask under your chin or store in scrubs pocket between the patients. The respirator strap should be placed on the crown of the head and base of the neck. Perform a user seal check each time you put on the respirator. User seal check means you just blow air, and if it leaks out from side, then it is probably not properly sealed and you have to correct it. Face mask, mask tie should be secured on crown of the head and the base of the neck. If the mask has loops, hook them appropriately around your ears. Put on the face shield or goggles. Face shield provide full face coverage. Goggles provide excellent coverage, but the fogging is common. Perform hand hygiene before putting on 2 pairs of gloves. Gloves should cover your wrist of the gown. Now the HCP may go to the operation room. Doffing, taking off the gear. Remove outer gloves first. Ensure glove removal does not cause additional contamination of the hands. Remove gown, untie all ties or unsnap or all buttons. Some gown ties can be broken rather than untied. Do it gently, avoiding a forceful movement. Reach up to the shoulder and carefully pull down the gown and away from the body. Rolling the gown down is an acceptable approach. Remove shoe cover, remove the inner gloves, dispose in trash receptacle, and now you can get out. One should follow the sequence properly. Remove face shield or goggles. After when you come out of the OT, then remove the face shield or goggles. Carefully remove face shield or goggles by grabbing the strap and pulling upward and away from the head. Do not touch the front of the face shield or goggles. Remove and discard respirator or face mask. Do not touch the front of the respirator or face mask. For the respirator, you remove the bottom strap by touching only the strap and bring it carefully over the head. Grasp the top strap and bring it carefully over the head. Then pull the respirator away from the face without touching the front of the respirator. For the face mask, carefully untie or unhook the ears and pull away from face without touching the front. Perform hand hygiene after removing the respirator or face mask and before putting it on again. Personnel. It increases with the procedures such as endotracheal intubation, tracheostomy, gastrointestinal endoscopy, and during the evacuation of pneumoperitoneum and aspiration of body fluids during laparoscopic procedures. Surgeons and persons not needed for intubation should remain outside the operation room till anesthesia, induction, and intubation are completed for patients with or suspected having COVID-19 infection. Now, these are the pictures of how the anesthetist should look like. Points to consider for GA. Minimize number of staff in OR during the intubation and extubation. Others can enter 15 minutes after intubation. Strictly follow donning and doffing of PPE as per CDC guidelines. Preferably, most experienced anesthesiologists should do intubation. Video laryngoscopy is preferred. Avoid awake fiber optic intubation due to risk of coughing and aerosol. Point consideration for GA. Consider rapid sequence induction, 5-minute pre-oxygenation, rapid acting muscle relaxant like succinylcholine. Avoid mask ventilation that can produce aerosol. If manual ventilation requires, do with less tidal volumes. Wear double gloves during intubation and remove one glove after intubation, sheathing one glove over the laryngoscope blade and send for the disinfection so that the glove do not contaminate the OT equipment.
Dr. Arif, please make it short.
HME filter. These are very important. Most important measures to prevent aerosol is 99.9% is protective against coronavirus. Use 2 HME filters. HME filters is one between the mask and endotracheal tube and Y-piece of the breathing system and another between the expiratory tube and the machine. During transport, EMBU bag should be connected distal to the HME filter. Gas monitoring like EtCO2 should be attached distal to HME filter. A minimum of 1 hour is planned between cases to allow OR staff to send the patient back to the
Hello.
ICU ward. Hello.
Dr. Arif, please make it short.
Please, sir.
Dr. Arif.
Okay. Electrosurgery unit should be set to the lowest possible setting for the desired effect. And surgical equipment used during the procedure with COVID-19 positive or person under investigation should be cleaned separately from the other surgical equipment. Incision of the port, for the laparoscopy surgery, incision of the port should be as small as possible. CO2 insufflation should be kept to the minimum and all pneumoperitoneum should be safely evacuated via filtration system. Since the virus has been found in multiple sensors of GIT and saliva and enteric content in blood, surgery and surgical energy should be minimized. Endoscopy procedures require additional sufflation of CO2 or room air where additional source should be avoided. Removal of caps or endoscopes should be released. Endoscope could release fluid or air and should be avoided. This is in short what we have discussed just now. If the transport of the patient with or suspected to have COVID-19 infection to an outside recovery area or intensive care unit necessary, hand off to a minimum number of transport personnel. Personnel should wear personal protective equipment. Going home safely. Be alert to the fact that viral contamination of the surface is known means of transmission of infection. Keep hand sanitizer and disposable gloves or use at ATM, vending machines, gasoline pumps, transfer items at the time of purchases. Clean your cell phone frequently. Consider removing clothes and washing them upon arrival home. Take proper bath with soap and shampoo. Consider reducing physical contact with family members. Clean hard surfaces at home with effective disinfectant solution. Protect your family, protect yourself. Take care, stay safe. Thank you.
Thank you. Dr.
Oh.
Naila, please come. Hello?
Dr. Alia, please start your.
Dr. Naila, please come.
Just a minute, I'm doing it. Hello, am I audible?
Yes, ma'am.
Good evening, all the online viewers. I'm Dr. Naila Siddiqui, and I'm going to talk about COVID-19 implications on dentistry and the guidelines for oral healthcare professionals. So, several dental care facilities in affected countries have been completely closed and only providing the minimum treatment for emergency. However, several facilities in some affected countries are still providing the regular dental treatment. This can in turn be a part of the result of the lack of universal protocol that regulate the dental care provision during such a pandemic. There's an increase in the nosocomial COVID spread through the dental care facilities, and on the other hand, deprive the patient's need of urgent dental care. Moreover, seizing the is it audible? Moreover, seizing the dental care provision during such a long period will incense the burden on the hospital emergency department that are already struggling with the pandemic. So the question arises with most of the dental healthcare professionals that when to start our practice, how to start, what should be done first, are there any specific steps, what are the emergency dental procedures, what procedures are not urgent and can be deferred, and how to manage them. So first things first, you should mention clear timings of your dental practice to avoid any chaos. Patient educative and instruction posters should be outside your waiting area. Physical distancing of 6 feet at all cost. You should schedule the appointment of the patient is if he is saying that he has traveled outside India, has any symptoms or was in contact with any lab confirmed case. You should give minimum appointments only after telephonic conversation so that you can triage the treatment into emergency, urgent, and elective. If you are thinking for an aerosol-based treatment, then complete medical and contact history should be taken, and you should send the patient for sample collection as per ICMR guidelines. Take the contact details, a name, age, address, preferably 2 phone numbers. Take temperature of the patient and record it on every appointment. PPE for procedures, which I'm going to talk about in the future slides that are coming up. Mouth rinses with 1% hydrogen peroxide or 0.2% povidone iodine. Clean and disinfect the clinical and public area, and try to make to take the payment through online modes. Now, such kind of visual alerts should be placed at the entrance and the strategic places where the patients are seated. Instruction about the hand hygiene, respiratory hygiene, and the cough etiquette. Try to put it in Hindi, English, as well as any regional or local language, whichever is spoken in that area. Provide ample supplies of alcohol-based hand rubs, soaps around the clinic, and no touch receptacles for disposal. Now, avoid haphazard practice of protocols. Just go step by step. Screen every asymptomatic patient meticulously, as any patient can be a potential asymptomatic COVID carrier. Consider the recovered patient as a potential carrier as well until 30 days have been passed after a lab confirmed test. Identify the urgent need of the patient and focus on the minimum invasive procedures. Precautions with proper aerosol generating procedures and PPE procedures. This is a sample screening format which you can ask the questions on over the phone when you're giving the appointment, or you can give this format to the patient which is seated in your waiting area. Get this filled, and you can check that if you have to deal this patient in your OPD or you have to send it to the government hospital for further COVID checking. Association of Oral and Maxillofacial Surgeons of India has given a declaration form to be signed by the patient. It is some sample from it. You can make one for yourself, and it says that the patient has voluntarily came to you to get treated for any emergency or dental problem, and he will adhere to all the precautions and the protocols which you will ask him to do. Take the patient signature and take the witness signature too. But for guiding development, we can divide the patients into 5 main groups: an asymptomatic and unsuspected unconfirmed case, a symptomatic and suspected unconfirmed case, stable confirmed, unstable confirmed case, and a recovered confirmed case. The dental procedures are also maybe divided into 5 categories. First is the emergency management of the life-threatening conditions. Second, hello.
Hello.
Sir, please continue. Please continue.
Okay. Urgent conditions that can be managed with minimally invasive procedure without aerosol generation. Urgent conditions that need to be managed with invasive and or aerosol generating procedures, non-urgent procedures, and elective procedures. So you got a patient, you did the screening, and you have an unconfirmed case and a confirmed COVID case. So if you have an unconfirmed case and he is asymptomatic and unsuspected, you can go with treatment category A, B, and C. That means the emergency and the urgent one. For the asymptomatic suspected case, you can just do the treatment category A, that is the most emergency procedure. If it's a confirmed case and an active disease is going on and patient is unstable, coordinate with the primary physician and go for treatment category A, that is the emergency treatment only. If the patient is stable but has active disease, again coordinate with the physician, and treatment category A and B, just these has to be given. If the patient has recovered and 30 days have been passed, you can go for full dental treatment. These are the most safest patient to do right now. And if 30 days hasn't been passed, then treatment category A and B should be performed. So what are the different emergency procedures that can come to you as a dental surgeon? Maybe an unstable maxillofacial fracture that is compromising the patient's airway, any diffuse soft tissue bacterial infection with swelling that is compromising the airway, any uncontrolled post-op bleeding or bleeding of dental origin. Then urgent conditions that can be managed minimally by any non-invasive procedure include any dental pain from pulpal inflammation that require tooth extraction, any fractured vital tooth, dental trauma, avulsion, pericoronitis, dental abscess, any fractured or defective orthodontic appliance that is impinging on the oral mucosa causing laceration. The urgent conditions that require aerosol generation are any dental plane that need to be managed with aerosol generating procedure, that is a root canal treatment. Any vital tooth fracture that need a root canal treatment, any avulsion luxation that again need an aerosol generating procedure, rebonded fixed prosthesis, removable denture adjustment for radiation and oncology patients, and so on. The non-urgent procedures include removable denture adjustments, asymptomatic fracture, defective restoration, any chronic periodontal disease, and so on. In elective procedures, all aesthetic dentistry procedures, dental implants, any cosmetic procedure, restorative treatment of asymptomatic teeth, all this will be included in the elective procedures. Now, AMFI has again given a protocol that should be followed while you are doing any minor surgery in dental clinic. You did a screening, it took the history and symptoms came to be positive. Then you should defer the treatment if symptoms are positive and get himself tested for COVID-19. If he is an asymptomatic patient, you can continue with the treatment, do the betadine mouthwash, plastic apron for patient, PPE, and surface disinfection, disposal of weight, and fumigation. The PPE will include that N95 mask with 3-ply mask over it, or alternatively, you can use a FPP3 mask as well. Face shield, 90 GSM gown with hood and shoe cover, double glove technique. Need of the time say that we should have these 3 gadgetries in our clinic. That is a HEPA air purifier, a high efficiency particulate arrestor, 30-watt UV light, and a fumigation machine. This is a protocol that you need to be followed when head and neck trauma patients come to you. The doctors and staff have to wear well-fitted mask and face shield, plastic gown, and gloves. Patient should be if patient is conscious and oriented, then you should take the history of COVID. If it turns to be positive, then take swab test. Send him for then you keep the patient under observation, conduct the swab test after recovery, take 2 consecutive negative tests and you should look for that if patient needs general anesthesia or local. If he needs general anesthesia, then operative negative pressure operating room with strict guidelines. And if he needs LA, then a dedicated operatory or the dental chair with proper guidelines and avoiding the use of aerosol, close treatment should be done. If the swab test comes to be negative, prepare for the surgery with minimal aerosol generation. If the patient is unconscious, then you should follow the triage protocol, and once the patient is stable, follow the guidelines that just been told. Now, a word about the mask and respirator, although which has been discussed already in the past presentation. I just need to tell you that masks are not designed to protect the wearer, contrary to our belief. We have been using since ever, but they just provide one-way protection to capture the bodily fluid that is leaving the wearer. They are worn before the surgery to prevent coughing, sneezing, etc. in the vulnerable patient, and most of them doesn't have a safety rating assigned to them. Whereas the respirators are tight-fitting masks, they are designed to create a facial seal. Null-valve respirators provide a good two-way protection. They both filter the inflow and outflow of the air, and they are usually have the safety rating of the mask. Now, PPE, a variety of PPE are available in the market, ranging from basic kit to advanced. You have to see that which type of mask do you need for a particular situation. If you are doing any procedure, or you are just in the OPD, or a visitor in the ICU or anywhere, you have to see which one is required at what situation. You have to be cautious that negative results do not preclude that COVID-19 infection is not there and should not be used as a sole basis for patient management decision. It should always be combined with clinical observation. You should take the guidance of physician regarding the radiological findings, patient history, and the epidemiological information. Now, specific treatment guidelines like no intraoral imaging should be followed. Always go for extraoral imaging because when you put IOP in the mouth, it induces gag reflex. Also, using extraoral radiography reduces excessive salivation. 1% povidone iodine mouthwash, disposable and single-use instrument. Rubber dam whenever possible. Treatment should be as minimally invasive as possible. Aerosol generating procedures should be avoided as far as possible. You should minimize the use of 3-in-1 syringe. High volume suction should be used. If you are suspecting confirmed COVID in case, you should always treat it in, you should not treat it in a routine settings, but should send the patient in negative pressure theater or airborne infection isolation room. Collecting, segregation, and transport of infectious waste should be according to the infection control guidelines. Now, PPE for staff and doctors, the hand hygiene should be followed as per WHO. I think by now everyone of us must be well versed with it. PPE mandatory now for all the procedures include goggles, face mask, surgical mask, N95 respirator for routine dental procedure, and FFP3 for COVID positive patients. They should be used judicially only when required and appropriately discarded. You have to change the mask after every dental procedure. All instruments should be disinfected, cleaned, and sterilized as per the infection control guidelines. Now, putting and the donning and the dosing have already been emphasized in the previous presentation. Just the type of PPE will depend on the level of precautions that is required. It should be very well tailor made for yourself. If just make sure that you're keeping the hands away from your face, limit the surfaces touched, change the gloves when they are torn or heavily contaminated, and perform hand hygiene. While removing the PPE, just keep in mind that you are removing the PPE before exiting the patient room, except for the respirator. If you have worn the respirator, then remove the respirator after leaving the patient room and closing the door. And proper sequencing of removal should be performed. If you have doubt that you have touched the outer surface of any part of your PPE, then wash your hands and use an alcohol-based hand sanitizer after removal. Some general instructions of trauma surgeries, many have been discussed already in the previous slides. Just want to mention few of them, like you should use scalpel over monopolar diathermy for mucosal incision, bipolar diathermy for hemostasis, avoid repeated suctioning irrigation. Self-drilling screws should be preferred. You should consider an osteotome when you are planning an osteotomy rather than power saw. Absorbable sutures preferred to minimize the unnecessary trip for removal. Conservative treatment should be followed, close reduction over open, and when it is necessary that open reduction and internal fixation has to be done, then transcutaneous approach should be preferred over intraoral approach. After the patient exits, at the end of the day, you should fumigate your clinic, ensure the dental unit water lines are flushed, back flush the suction pipe with 1% sodium hypo, sterile and the oil the handies, remove couplings and air motors from tubings, clean the suction and spittoon filters. I think all this, as a dental surgeons are already doing it in our clinic. You should be just more vigilant regarding all these things. Once you reach the home, you have to make your family safe. Do not touch anything until you have washed your hands, remove the dirty clothing, sanitize your phone, shower and wash the most exposed areas. An advisory, the government advisory came yesterday on 19th May, and I have included this slide few minutes before the presentation. They have divided the zones according to the dental clinic provision and the opening. So dental clinic, they said the dental clinic will remain closed in the containment zone. However, they can seek the ambulance services to travel to the nearby COVID dental facility. In the red zone, only emergency dental procedures can be performed. In orange and green zones, dental clinic can function to provide the regular dental consult, but the dental operations should be restricted to emergency and urgent procedures only. All routine and elective procedures should be deferred for a later review until new guidelines are issued. Due to high risk associated with the examination of oral cavity, oral cancer screening should be deferred until new guidelines are issued. So, to put in a nutshell, our primary goal is to provide safe, effective, and responsible treatment for our patient while minimizing the risk to the community.
Thank you.
Hello?
Thank you so much, Dr. Naila. Thank you so much.
Okay, I'm done. Thank you.
Thank you so much, ma'am. Just before leaving the webinar, I want to ask one thing on behalf of our GM, sir, Sanjay Mohite. He asked during the calling, a medical representative with the doctors, chemists, all, what precaution he should take, all salespersons in the field. Dr. Naila?
Yes.
So can you guide us?
Yes, of course. As a person who is sitting in the medical store, he can use a 45 GSM PPE. That is all that is required for him to wear.
Okay, so we should wear that PPE kit during our visits and all.
Not any PPE, just the
45 mm PPE.
Yeah, that
Yes,
is only required for him. Nothing else.
Thank you so much, ma'am. On behalf of Elan Pharma, I'm so much thankful to all doctors and viewers who are participating in this session. Thank you, Dr. Taj Mohammad Khan, for making this possible webinar. So just
thank you very much. Okay. Thanks, everybody. Thanks.
Thank you so much. Thank you so much. Good evening. Okay.
Good evening.
सर स्ट्रीमिंग स्टॉप कर दूं?